All right. So here's our off week in between grand rounds 7 and 8. We've had a couple more people join, had some good questions. I know last grand rounds we really hammered down on exam. I don't want to bring up a case that was specific to exam, but I don't want to really present this as a case study because I want to talk about a couple things and I don't want to get too lengthy, and I don't really think it also warrants a whole uh, case study report. So basically, this is a 42-year-old male, had recently moved to Birmingham, and was complaining since this. I would have seen him. This was last year. I saw him in June, and as of January, he was having complaints of bilateral Achilles pain, kind of insertional Achilles pain, where it would kind of wax and wane, vary right versus left, and then also bilateral knee pain, and it was patellar tendon pain, and really kind of ischial tuberosity pain. So this is my clinical pearl here. Anytime you hear of bilateral pathology, let's say it was just the knees or the Achilles, bilateral anything, the first thing I think we're all thinking is probably central, right? That it's pretty rare to have tendinopathy, legitimate tendinopathy or tendinosis bilaterally that's actually the driver of symptomatology and, the tissue that we're going to be working on. Like I had a virtual consult today with bilateral gluteal tendinopathy on it, positive on MRI. I highly doubt that's what's going on. Anyways, so now we're digging into the history part of this exam pretty hardcore. And what's one of the things that if you've heard me talk about soft tissue pathology, in particular tendinosis, now you're seeing bilateral with no real increase in activity. I think he started playing a little more basketball. He started playing pickleball. Is that you have to question, hey, what changed, right? Environment as far as activity, exercise, work, medications was the question here that became important. And lo and behold, before coming to it, so he's from Canada, before coming to America, he had dealt with upper respiratory infections pretty gnarly in the fall. So this would have been backing up into 2019, around September, October. He did 2 rounds of Cipro, and we've had a couple of patients go through the same thing. And unbeknownst to him and unbeknownst to a lot of people, fluoroquinolones have a pretty gnarly effect on the way that you reproduce collagen, in particular while you're taking it. And then it also has kind of a reverb effect or ripple effect farther down the road. But if you're doing the same amount or up ramping activity while you're on these medications, there's a high likelihood for tendinopathy, but specifically insertional tendinopathy, just due to where the stress strain load is on the tendon where it inserts into the enthesis. So I don't just say, well, you took this medication, here we go, you got to let this run out of your system. Because here's the other thing is this takes a while to, change. And I'll show a slide here in a second on, the tissue remodeling windows, but we're thinking tendon is in the window of probably tops max resolution, like 60 weeks. If we're thinking about, depending on what status we get in here. And right when this guy comes in, there's no inflammatory signal, right? It's not red, hot, swollen. It's barely tender to the touch. He really has to load it. So I told him, hey, it would behoove you to work on some of the functional medicine aspects of this, really clean up your diet. There's things that you can do from a functional medicine standpoint, like IV therapies, as far as glutathione drips, HOCAT treatments, hyperbaric chambers that have, not specific outcomes as it pertains to tendinopathy. But when we think about an uptick in mitochondrial activity, peptide treatments, all these things are going to show that they do what? They increase the cellular respiration rate or the mitochondrial energy output. And when that happens, you're going to have a better ability, which gets knocked down by the fluoroquinolone, to then heal that tendinopathy, or at least manufacture whatever tendon is being replaced in like a reactive tendinopathy or something like that a little bit better than you would have. So in the meantime, what do? We try to increase tolerance. And then it's this kind of razor's edge with these people of, too much and too little, because they're already in pain. So, it's a lot of isometrics. It's your typical, tendon rehab continuum where, make sure that the things move appropriately. And what else does this guy have going for him that I guess we should point out? He's really mobile except through both of his big toes because he was a lifelong soccer player. And he's having Achilles and anterior knee pain. So in my mechanical mind, I'm thinking, well, if he's going to stop short on big toe or hallux extension, he's going to have to drive excessively through his ankle and his knee to make up for that, whether it's sprinting, jumping, walking. So here we can see that there's going to be a little more a direct strain on the enthesis at the Achilles, but then a little more shear load as we're going through kind of the roll phase with, tibiofemoral joint mechanics. So it's just creating tolerance. You can get really specific with that. We could think about blood flow restriction training. We could think about some other supplementation, but I'm using this case as a, hey, make sure that not when I hear bilateral etiology or chief complaint that it's oh, it's fluoroquinolones. It's, hey, what are we thinking? Possibly, central, canal stenosis, central disc protrusion, something central that's driving bilateral pathology, something systemic, right? Autoimmune issues, medication changes, Accutane, things like that. But that's coming out of the exam of knowing okay, what was the other part of the exam that confirmed that for me? It's not just the history, it's the exam. The fact that it was really hard to reproduce pain on this guy unless he did a lot, right? Unless he sensitized these tissues more, even though he said this was pretty much chronic. So it's not like he's not in pain, but it's also, there's no positive orthopedic test, not really tender to the touch. So that also tells me, well, this isn't a true, tendinosis. He's having a bit of a reactive tendinopathy due to a medication change at this point. And there's a lot of things we did some dry needling to help, increase an inflammatory response because it'd been going on 7-8 months since the initial kind of onset of whatever, tendinopathy, when we're going to classify that as. But that's, there's my little case on be specific. And we could be specific on any part of the exam. You're like, man, I really need to be good at palpation, or make sure I didn't miss palpation of, lumbosacral counternutation on this stenotic patient, because getting them to be able to counternutate really sped up the process of reducing symptoms and increasing functioning, of getting them out of maybe bilateral symptoms around the hip. But I think it's important that in that history of making sure that you're going through the review of systems, right? We look at the paperwork, use the review of systems as a guide, but there's just certain questions. And I hit this during our talk that, surgeries, medications, changes to environment, duration of tasks, different types of tasks, stress levels, sleep, all of those need to be hammered, even if people don't mark it, because they're oftentimes not going to mark it or fess up. So now on that same kind of progression or timeline, let me share my screen here, because Kyle Utley, one of our new members, brought up or asked in a message if I had listened to the Gestalt podcast with Lynn Fay, and I had. And I don't know, Kyle just said, hey, there's some things in there that I am interested to get your take on. One of the things that, maybe it's one of Kyle's questions, maybe it's not, but that I thought was interesting is Lynn Fay kept alluding to the fact that we're severely undertreating people in musculoskeletal care. So now, use my example, the guy here. Did I see this guy for, if we look at this timeline of the tendon continuum to get back to normal tissue, the ability for the tissue to get back to normal after an acute or chronic injury, we're looking at the timeline for max tolerance is way out beyond 100 weeks. And there's a bunch of variables in there, right? Consistently tearing it down, diet, all these things. But that's a lot of time, versus what do we see with muscle and bone and a little bit with ligament? It's a really steep curve, and then it just levels off. And we do, it hits that leveling point way faster than in particular tendon or cartilage. That being said, did I see this guy with this fluoroquinolone issue for 100 weeks? No, I've seen him for other stuff, and we check in on that because I needed to teach him how to create load, how to progressively overload, what to stay away from, basically desensitize and then build shit back up. If that's how you want to say it. But the flip side of this is, okay, there was a systemic response with pain as the subjective kind of outcome. What about somebody that's actually had tissue damage, or we're looking to have tissue adaptability to create functional outcome change? So what would be two of those? Let's take an ankle sprain with a grade 2-3 sprain around that ATFL or CFL. where now we've had major tissue damage to something like a ligament, and the ligament window for peak kind of adaptability is in that 40-week window. So 40 weeks is going to take us way out way out past most of our normal treatment plans, right? So if we're thinking, 4 to 6 visits, we're just ramping it up. That's a trial of care. 4 to 6 visits puts us where? Under a month, like way under a month. 40 weeks puts us where? Like way out beyond 5 months. And that's what Lynn was kind of saying here is that, hey, and he kept speaking about ligaments. He's like, when we're thinking about changing tissues that haven't been changed in a while, because he's saying if we have true joint restriction, that you've probably had tissue adaptation, right, within these same time windows and maybe longer. And then we're trying to create change. Let's take the example I just said a little while ago about lumbosacral nutation. So now we're looking at all of the, sacroiliac and lumbosacral ligaments that are surrounding there. And maybe there's been, hysteresis over time, and then we've had a bit of calcification and maybe some fibrotic change. And Lynn's thought was that, and we know some of those ligaments can be pain drivers. That's not commonly what we're going to see, but they can be. And he's saying, well, are we just trying to change pain, or are we trying to change function? And that's changing function is this big fuzzy debate, right? And I mean fuzzy, not like warm and we all want to hug and kumbaya, like fuzzy, like it's hard to kind of create clarity around it. Because what if I'm saying, well, I think improving function in somebody, and my objective outcome of that is my palpation, my hand-on manual palpation of lumbosacral counter nutation. And I think via that, because now I've got them out of pain, right? Let's say they're out of pain, and now I'm saying, man, now I can feel motion. And I'm sure there's some sort of objective outcome measuring of off-cyc lens, as far as movement too, global or, local movement of, hey, now they can plug that lumbosacral counter nutation into a movement, functional change. Or do we say, I'm not so worried about the hands-on portion, right? I am, but I'm not so worried about that. I want to see global change. I want to see, do they have improved lumbar flexion overall? Do they have an improved multisegmental flexion? Whatever it is. Those things don't necessarily, it doesn't mean just because they get improved lumbosacral counter nutation, they're going to stay out of pain. We would think they would if we're on the right path, but it's really hard to write these narratives around pain, which we also talked about in the last grand rounds. So all I wanted to point out here was, and I'm guessing, I may be completely wrong, this is one of Kyle's questions, that do I think that we're severely undertreating? Do I think that other chiros are severely overtreating? I think chiropractors that are seeing somebody like if you watch the Burn Your Treatment Plans YouTube video I put out, where somebody drew up a treatment plan for a 13, 14-year-old girl for a chief complaint of anterior knee pain or Osgood-Schlatters, with mainly looking at cervical spine adjustments for 44 visits, which is a long time. That's way over the 40-week window in this case. What's the functional outcome there, right? Decreased pain in the knee? Well, cool. Of course it did. You had 40 weeks to bang around on her neck. I don't think that's right. But do I also think it's right that if, let's say, that same girl with, let's say she comes into your office with acute inflammatory signaling, it's red, hot, swollen, tender to the touch around that ischial tube, and she's going through a growth spurt, and then it takes you 8 visits to get her out of pain. Do you think, and maybe there wasn't a functional or a dysfunctional driver of pain in that scenario. Maybe we're thinking she went through a growth spurt, she's just been doing a lot. And, that's kind of a common thing. And usually we back them down, we increase tolerance, and they go about their way. But what if it wasn't, right? And not everything, I believe that not everything is tied to dysfunction. I see plenty of kids that come in here with a growth spurt related thing that, like, hey, my AIS is a little hot. My, whatever, it looks like Sievers. It's not, right? There's no, these things do happen, but largely especially in the population now of children and adults, the inability to pick up something to work on, I don't think is going to happen unless you're just looking to get a paycheck or you're just not very good at the power of observation. So I would say I severely undertreated people for a long time. And that's something we're pulling ourselves out of, because once you indoctrinate your patients to it, it's what they get used to, because they get used to getting out of pain. And if you're good enough at educating them on what they need to do, it creates a safety net, right? Because I've educated them on, hey, this is what we're working on. Let's say it's your ankle mobility to decrease knee pain. Your patellar tendon is beat up, so we're trying to sensitize that with some isometric loading. The long-term goal is improve central stability while we're working on that ankle mobility. And let's just say they're a stud or, stud at, and they do all that. Awesome. But that's rare, right? So I think it becomes more of an exercise in hand holding, making sure that we have good objective outcome measures instead of saying, hey, you're out of pain, your ankle's doing a little bit better, but like, what are we looking for, right? And that's one thing that in other offices, and I'll call us out. I don't think we've done a great job at return to play criteria, which I was definitely schooled in while I was at BioFreeze at Logan. It tends to be more what we did for a long time was get people out of pain, have a good functional audit, right? Change that function. But then like, were we really going through a battery test of like, can you put that functional change into what you need to do? So for, some people, yeah, we did great. Other people, I think we let them kind of fly because of, oh, they're not a stud athlete. They're going to go back to CrossFit. It's kind of fine, right? Or they have a multitude of things we could work on. Or like, oh, we got their knee doing better in their, because we got their hip moving better, stabilizing better. And then we just let other stuff go because we think people won't keep coming. It's tougher to explain why they need to keep coming. We feel bad that if we keep them coming, we're in the same boat as other chiropractors. If you think you can help somebody with something, why aren't we telling them that? And again, I don't know if this is Kyle's question, but this is what I want to get to. So now we get the case study I was talking about, the fluoroquinolones. Now we get a little business talk that, use this slide. There's probably a much better slide nowadays. I did some work on this one, but like I've thought about having this tissue adaptation window in my room, not to catastrophize that there's always a pathway anatomical cause. But if we can denote that there is, I think as a physician, right, as a chiropractor, we gotta pay homage to that and say, hey, we're gonna work until we're really sure that that's doing really good, not until it's perfect, but also make sure that the function that was either the functional adaptation that may have led to that, or that we think it can improve and offload that scenario, is what we need it to be. And if we can rule out pathway anatomical causes of pain and get somebody out of pain and get them feeling better in 6 to 8 visits, cool. I just think that we often are not that good at deciphering those two. So maybe that's what we need to talk about in an upcoming grand rounds or off week is how are we actually picking up, besides, are we going to run everybody in an MRI and ultrasound? We know how that pans out. One of my virtual consults today showed me an MRI with gluteal tendinopathy, right greater than, or right worse than left. Had bilateral hip pain. This guy is in London, but I do not think that his hip pain is driven by that, but he's showing me MRI signal that's, white hot on these tendons. That could be for a variety of reasons, but the exam beyond that and his history does not match what that MRI says. So again, it's matching all of that stuff. I've said it, if ask any of our docs in here, interns, how many times they've heard me say, by the time I send somebody for advanced imaging, 95% of the time, I know what's going to be there. There are those times where you're sending people for imaging because you're like, this does not make sense. Stuff is not going right. It's not working out right. Then you're looking for what? Red herring stuff, right? The stuff we don't want to have to deal with. Red flags we got to rule out, or just, man, it's something different than I thought it was, right? That's going to happen. But that does what? When you keep going back and forth through those feedback loops, you're building your intuition and clinical skills by saying, I thought it was that. Oh, it is that. Okay. I thought it was that. Oh, it's not that. But I think we need to do a better job of like not shoving off imaging, not shoving off like things like orthopedic tests, and not shoving off, anatomical and tissue pathology. That stuff is happening more often than not, especially nowadays with systemic health declining and the availability of nutrients and movement and things like that being very low in somebody's life, and then they want to go work out and then thinking that the tissue's just sensitized. Well, it's probably shitty tissue too. So like, are we doing our jobs to build those things up? And I think if you want to do the best thing for the patient, whether we're saying, capacitize the tissue, get a joint moving appropriately, and how much work that actually takes to make that stick, right? Or create sustainable long-term mobility or movement change, joint by joint or multi-joint segments. I think it's much more than you think, but it is a business play that you do need to see people a certain amount of time and get paid for your worth. And you toe that line, but that doesn't mean that you see everybody 2 times a week for 6 weeks and then 1 time a week for 6 weeks. And it's, hey, what do I have going on? And make a plan based on the tissue at hand, the patient at hand, And then you're going to have, hey, I need 6 visits. Hey, I need 14 visits. Hey, I need 12 visits. We're going to check back in. Like, be smart. Do what you would want to do. If you had an injury, you'd want somebody to treat you all the way through it. I guarantee you would not want somebody to treat you as fast as possible, release you back to the wild with a higher risk profile. That's not what you want, even though that's what we do with a lot of people, because we think that even though we say it's not what we're doing, we think that getting them out of pain is the main thing. And then we're like, because while we're getting them out of pain, you're able to improve a little bit of ankle flexion, a little bit of hip internal rotation, a little bit of intra-abdominal pressure. Is it enough? Was it good enough for the task at hand? Did you battery test them? Did you give them enough time in between, the second to last visit and, their ejection visit, as we would call it, to actually see how do they handle 2-3 weeks of doing what they're doing before we say, hey, you're good to go. So there's my 2 cents on exam specificity, in particular on the history, timetable, kind of looking at tissue adaptability and how we program. And we can get really specific on treatment plan, formulation and delivery. If that's something that all of you want, you can let me know via like the Facebook group or on the next Grand Rounds. And then how we go about, explaining this stuff to people to make sense to us that, there are people that I see 1 time or 2 times, especially existing patients, like something's a little tweaky. They come in, I've seen them. I know what's going on. I'm not trying to make a big change around this area because I have a baseline, right? And I've seen how things work out. They did sleep a little funky. They threw up some weight. And it's, 1 to 3 visits. Cool. You're back out of my office. I'll see you next time something happens or when you want to follow up for a wellness visit or something like that. So keep that in mind. It's a good conversation to have. I don't know if that was one of your questions or not, Kyle, but something that I thought was interesting that Lynn said. So hope you all got something out of this, and I will see you all next week.